which none of us as a surgical oncologist or even as a oral pathologist can teach you. This is extremely important topic, and we have no idea how vast it is and the amount of clinical knowledge, experience, acumen we need it. My whole, last 2 to 3 decades, I've been terribly impressed with Dr. Srinivas, who is, FD SRCP from Glasgow, UK, and a oral physician. I'm amazed when I get this peculiar type of oral lesion. I just send him and one line, 1 second, he will make the spot diagnosis and the treatment. Then I was amazed. Such a huge 3-year training program is there in oral disorders that we need to understand what are the pre-malignant, pre-cancerous lesion, how do they look. The vast collection of cases he has, he can write 3 encyclopedia of various disorders of oral cavity. Extremely busy but very, very good human being, excellent clinician and very academician. So it's my honor today to invite Dr. Srinivas today to enlighten all our students. Thank you very much, Srinivas, for accepting this. And this goes a long way in teaching us, my student, me, and everybody. Thank you very much, and over to you.
Thank you very much for the kind introduction, sir. Sir, please remember, whatever we are today, it is all because of you medical colleagues. People who have recognized our knowledge and you have been giving us cases. We have got an opportunity to share our knowledge only because of medical colleagues, sir. Thank you.
Thank you. Thank you.
Good morning, one and all. My dear friends, today I am going to discuss about oral potentially malignant disorders. Well, these are defined as lesions and conditions that are not malignant, but they have the potential to become malignant. Well, previously they have used the terms pre-cancer, precancerous lesions, precancerous conditions, intraepithelial dysplasia, intraepithelial neoplasia, so on and so forth. The terms pre-malignant and precancerous are often used interchangeably. However, the current consensus and the internationally authors believe that the term potentially malignant better expresses the uncertainty of progression to cancer. See, various clinical, histopathological and molecular features are indications for an increased potential for malignant transformation. I think we should stick on to the term oral potentially malignant disorders, which was adopted by the WHO Collaborating Center. Pre-cancer should not be used because it literally means that at some point of time, this particular lesion is going to result into a cancer. So with this introduction, we will just enlist what are the oral potentially malignant disorders that we get to see inside the mouth. Number one, oral leukoplakia that you people are very commonly seeing, erythroplakia, oral submucous fibrosis, palatal lesions in reverse smokers. Now, this particular lesion, the palatal lesions, is a very, very rare entity. It is seen exclusively in the coastal part of Andhra Pradesh and border of Orissa. Andhra-Orissa border, you will see these lesions. In this particular area, people, especially women, they smoke chutta in a reverse direction. That means the burning end of the chutta is held inside the mouth and they suck it. In these patients, you will see some red areas in the palate. There are some changes that you get to see in the palate, and most of them are dysplastic. That is the palatal changes associated with reverse chutta smokers. Next, the oral lichen planus. Oral lupus erythematosus, the oral manifestations that are as a result of systemic and discoid lupus erythematosus. Actinic cheilitis, of course, you people are very well aware of that condition. There are 2 hereditary conditions which also are considered as potentially malignant disorders, namely the disc keratosis congenita and epidermolysis bullosa. In the year 2007, the WHO and the cancer meetings also decided to put the oral manifestations of graft versus host disease and the lichenoid lesions. The lichenoid lesions means all the lesions that you have studied in your undergraduation in dermatology, that can have oral manifestations that include lichen pemphigoides, oral lichen planus, atypical lichenoid stomatitis, lichenoid dysplasia. All the conditions which come under lichenoid lesions which have oral manifestations are essentially to be considered as oral potentially malignant disorders. Now the question comes, in this 1 hour, I cannot discuss all the diseases that I have enlisted in this particular slide. So what I have picked up is, I have picked up the most prevalent ones and the most common ones that we see in our clinical practice. So I will be discussing today about oral leukoplakia, oral submucous fibrosis, oral lichen planus, and few other important points that I would like to share with fellow oncology colleagues. So let us start with leukoplakia. Now, we all know, everybody knows that you are seeing leukoplakia on a routine basis, but since it is a lecture, I am telling it in a proper manner with all the latest updates. By definition, leukoplakia means it is a white plaque of questionable risk for malignant transformation, having excluded other known white lesions or disorders that carry no increased risk for cancer. Now, what are those known white lesions? There are a plethora of known white lesions that can present as leukoplakia, but you people are very well aware of that. But I am including some important ones which we routinely see in patients' mouth and are confused to be leukoplakias. Let me show you one by one what exactly are those lesions and what are we talking about. Essentially, by definition, if you see, leukoplakia is diagnosis of exclusion. So the first condition that I want you to differentiate from leukoplakia is a normal variant of the oral mucosa, which is called linea alba buccalis. As the name suggests, you will see a keratotic line on the buccal mucosa, which is white in color. That is why it is named linea alba buccalis. What is this? This linea alba buccalis is a horizontal asymptomatic white linear lesion on the buccal mucosa at the level of occlusal plane. The upper and lower teeth, wherever they are occluding, that particular area causes pressure, and because of the frictional irritation, there is a keratosis on the cheek, or the sucking trauma also. It's basically caused because of the facial surfaces of the teeth causing a keratosis or indentation on the cheek. It is routinely mistaken for leukoplakia. My dear friends, this is a normal variant of the buccal mucosa. It is not leukoplakia. It is called linea alba buccalis. Yet another linea alba buccalis on the right buccal mucosa. In some patients, this particular linea alba, if you see, there is a horizontal line, and when it terminates in the retrocommissure, it terminates in the fashion of a V, alphabet V, like this. The next condition that we are going to talk about is called as leukedema. Leukedema. This also typically looks like a white patch on the buccal mucosa. Normally it occurs in the buccal mucosa. How does it appear? Leukedema is a blue or a grayish white appearance of the mucosa, particularly on the buccal mucosa and inside the cheek. It may also occur on the mucosa of the larynx and vagina also. There is a diffuse grayish white milky opalescent appearance. That opalescence you can see here. This entire area looks opalescent. Opalescent, which usually occurs bilaterally on the buccal mucosa. Now, how to diagnose this particular disease? It's not a disease, a normal variant, I'm sorry. The characteristic feature of leukedema is, if you take a mouth mirror or any instrument just like a tongue blade, if you retract the cheek, the white lesion disappears. Because this particular lesion is being seen like this because of intraepithelial edema. So the moment you retract, you get to see that the lesion has totally disappeared. When you relieve the mucosa, again the white lesion appears. This is how you diagnose leukedema. Again, this is not leukoplakia. The third condition is choroiditis granules. I think you all are aware of it. It's a collection of sebaceous glands that occur in various locations of the oral cavity. It can occur on the lips, labial mucosa, buccal mucosa, so on and so forth. Definitely not leukoplakia. But sometimes the color is such that we get confused to leukoplakia. So we need to differentiate it. There is something called traumatic keratosis, frequently seen in the retromolar trigone. What happens in this retromolar trigone area is, patients who have got sharp teeth or patients who have got chubby cheeks, what happens? The molars will cause trauma whenever the patient is trying to open and close the mouth while eating or talking or whatever. That induces an amount of keratosis. You can see there is a sharp margin of the second molar tooth here, and there is significant amount of keratosis in the retromolar trigone opposite to the sharp borders of this particular tooth. So this is traumatic keratosis. You will have to palpate and look for sharp teeth or sharp margins causing keratosis. This is definitely not leukoplakia. Last but not the least, I know most of the patients come to you with geographic tongue. Sometimes the geographic tongue classically presents as a depapillated area surrounded by too much of keratosis. Sometimes patients will feel this is leukoplakia and they come to you. At the end of this presentation, we will discuss about what is to be done when patients present to you with normal variants of geographic tongue thinking it as leukoplakia. But sometimes in this particular slide, you can see that the plaque appears just like leukoplakia. We need to differentiate this. This is definitely asymptomatic lesion. We need to differentiate it from leukoplakia. So once you know that you have diagnosed a leukoplakia, which is a diagnosis of exclusion, the textbook and the literature says it is idiopathic, but the exception is smoking. My dear friends, all forms of tobacco, smoking and chewable forms of tobacco are known to be etiological and exacerbating factors of leukoplakia. Let's look at the natural history of oral leukoplakias. It can be caused because of smokeless and smoking tobacco. Tobacco along with aracanate, the commonly available pan masalas are also a risk factor for causation of leukoplakia, and of course, alcohol is a synergistic risk factor in causation of leukoplakia. The leukoplakias can be asymptomatic or symptomatic. Generally, all homogeneous leukoplakias where there are no red components, they are asymptomatic, and the moment you see a red component, the speckled or the non-homogeneous leukoplakia, basically because there is a loss of mucosal barrier, in the red areas, patients will start complaining about burning sensation and consuming hot and spicy food. Now, another important point that we need to keep it in mind when we are treating leukoplakia is all non-homogeneous types of leukoplakia greater than 2 centimeters are colonized with Candida albicans. We'll come to this point when we are discussing the treatment part. So this is about the natural history. Now we talk about the types of leukoplakia. In the types of leukoplakia, we have homogeneous leukoplakia and non-homogeneous leukoplakia. In non-homogeneous leukoplakia, we have nodular, speckled and verrucous and sometimes exophytic type of leukoplakias. Let us see one by one how exactly it looks and what exactly happens. Homogeneous leukoplakia is a typical lesion. You cannot miss it. The typical homogeneous leukoplakia is clinically characterized as a white, often well demarcated plaque with a similar reaction pattern throughout the lesion. See, it's very well demarcated, similar pattern throughout the lesion. Some lesions are uniformly presented in the entire area, but the surface texture can vary, even in a single case, from smooth and thin to a leathery appearance. And in some cases, you will get to see some surface fissures like this. And some authors would like to refer these surface fissures as a cracked mud appearance. So homogeneous leukoplakia, please remember, well demarcated, consistent pattern throughout, cracked mud appearance, non-scrapable white patch. This is homogeneous leukoplakia. So I have shown the example of 3 patients here: alveolar mucosa, dorsal surface of the tongue, and the palatal aspect of gingiva in relation to the central incisor. 3 more examples of homogeneous leukoplakia. This is on the buccal mucosa. This is on the dorsal surface of the tongue. This is again on the lateral borders of the tongue. When you talk about the non-homogeneous kinds of leukoplakia, the first one will be the speckled leukoplakia, which presents basically as mixed white and red in color. It can also be termed as erythroleukoplakia. Some authors would like to call it as erythroleukoplakia. It is synonymous to speckled leukoplakia. In speckled leukoplakia, what you get to see is a red and white lesion, but retaining predominantly white coloration. Predominantly, you will get to see white color, but you will also see red color. These are the patients who are symptomatic. So you can see a red and white lesion in the first and second picture. You can see small keratotic nodules here in the third picture, along with erythema anteriorly towards the commissure. This is nodular leukoplakia. And this is a verrucous leukoplakia or exophytic leukoplakia, which is very, very white in color. Corrugated and wrinkled appearance of the surface is noticed here. You cannot miss this diagnosis of verrucous leukoplakia. That verrucoid appearance is classical, which is basically wrinkled or a corrugated non-scrapable white lesion. Now let's talk something about the risk profiling. If you want to treat a leukoplakia successfully, you need to categorize leukoplakia under low risk and high risk. What are low risk leukoplakias basically? Any lesion that measures less than 200 millimeter square or 2 centimeter square, if it is a homogeneous type of leukoplakia and if involves anatomical areas inside the mouth other than the tongue and floor, it needs to be considered as a low risk leukoplakia. It needs to be treated as a low risk leukoplakia. Any lesion more than 200 millimeter square, if it is a verrucous leukoplakia or a nodular leukoplakia or an erythroleukoplakia, any kind of leukoplakia occurring in the tongue and floor of the mouth, any kind of leukoplakia affecting the females, if the age of the patient suffering from leukoplakia is more than 40 years, if the patient is having a family history of cancer, and most important point, if it is a non-habit associated leukoplakia, you will have to label it under high risk leukoplakias. You will have to label it under high risk leukoplakias. Now, I would like to add up a note on the reporting and criteria for grading dysplasia. I wantedly added this slide today here because, if somebody can make decisions regarding this, it is only oncology colleagues. You will have to bring about this change in our community. See, instead of grading histopathologically as mild, moderate and severe dysplasia, I personally feel and suggest that a binary system of classification will be better when you look in terms of management of these lesions. It complements WHO classification systems and critical decisions can be made with regards to moderate dysplasia only if you can classify it into binary system. And if everybody starts following this, it becomes a standardized approach. Nowadays, it has become increasingly popular and it is not suggested now. I have put a table where from 1978 to 2006, how people have subclassified histopathologically, how they wanted to grade the dysplasia. Way back in 2005 itself, it was suggested to divide the dysplasia into low grade and high grade dysplasia. I think this particular grading system is very, very useful and there can be a better management of patients here. Because sometimes we get to see that even in moderate dysplasia, it tends to transform into cancer. I think only a low-grade dysplasia can be managed with pharmacological modalities without excision and periodic observation. So this is my sincere request to all the oncology colleagues to think about it. It's very easy to give a histopathological diagnosis in binary system. It is well documented in the literature. More than 4 cellular changes and more than 3 architectural changes will be decided as a severe, a high-grade dysplasia, and anything less than this will be decided as a low-grade dysplasia. I think you people are well aware of these cellular and architectural changes. I'm not going into the details of these things now. How do you manage leukoplakias? As we have decided, and I have shown you that the leukoplakias can be divided into low-risk and high-risk leukoplakias. Low-risk leukoplakias, most important, as you all know, cessation and counseling. For cessation, you can talk to the patient, you can take the help of psychologists, you can start the patient on tobacco cessation therapy. Please remember, I spoke to you about candidal colonization. What I do in my practice is, irrespective of whether the lesion is more than 2 millimeters or 2 millimeter square or less than 200 millimeter square, I start with a topical antifungal. You all are very well aware, there is only one oral topical antifungal available in India, that is clotrimazole, available as candid mouth paint. Ask the patient to apply it on the lesion, leave it for 3 minutes and then rinse. Use it for 3 days, 3 times a day, at least for a period of 7 days. The second point is all low-risk leukoplakias to be managed with topical vitamin A, 25,000 international units, twice a day for a period of 90 days. Now the question comes, there is no topical vitamin A available in India. What I generally do in my practice is, this vitamin A gelatin capsules are available in the market. One of the market names you all are aware of is Acusol A. What I ask my patients to do is, I ask them to puncture this particular gelatin capsules and express the liquid, the vitamin A liquid present inside the gelatin capsules on their index finger and apply onto the lesion. So you are getting a topical application, you are getting a required dosage, so you also can practice this. Along with this, 75 grams of green leafy vegetables per day, consumption of fruits which are rich in antioxidants, guava and papaya, and periodic and regular surveillance of patients is very much recommended for management of low-risk leukoplakias. Now, one important thing that you need to keep it in mind when you're giving vitamin A as a topical thing is, It has been reported that patients using vitamin A, even in topical form, there are some reports that it causes bone thinning, liver damage, headache, diarrhea, nausea, skin irritation, pain in the joints. So please keep these adverse effects in mind and periodically review the patients for the side effects. Now, coming to management of high-risk leukoplakia, the moment you know it is high risk, you have to do an excisional biopsy, and based on the report, if there is a high-grade dysplasia or a carcinoma, you are the best people to manage it. If it is a low-grade dysplasia, then whatever we discussed in the previous slide, the same protocol needs to be followed. This is how you manage high-risk leukoplakias. I have basically shown two pictures here, the low-risk leukoplakia, a homogeneous leukoplakia, and the left buccal mucosa here. What you are seeing, we have used topical vitamin A. Follow-up after 1 month, you can see the amount of keratosis and a mild erythema that is present on the anterior margin of this particular lesion has started disappearing. Another patient, leukoplakia in the labial mucosa. This is associated with chewable tobacco. You can also see the tobacco stains here. You can see follow-up after 1 month, there is a significant reduction in the size of the lesion after topical vitamin A therapy. Now we will discuss about a condition which is very, very important. There is something called as proliferative verrucous leukoplakia. It is uncommon, but it's a very serious condition. It starts as a homogeneous leukoplakia, but over the time it develops, it gives a verrucous appearance containing various degrees of dysplasia. One important thing about this particular disease is the pattern of clinical behavior does not match with the histological features in the initial stages. Now, this is how a verrucous leukoplakia looks. This is how a verrucous leukoplakia looks. Generally, this verrucous leukoplakia, it starts as a homogeneous leukoplakia, as I told you, but it starts giving this verrucoid appearance and it involves larger areas of the oral mucosa. It has got a very high malignant potential, generally seen in older women, and most prevalent and most common site of occurrence is the lower gingiva or the lower alveolus. And majority of the times when you do a biopsy, it doesn't look like a cancer, but the histopathological diagnosis will be already verrucous carcinoma or squamous cell carcinoma. This is how I have shown you. This is a lower gingiva. Of course, the teeth are not there. That is why we term it as lower alveolar mucosa. You can see a widespread verrucous appearing lesion. This is a proliferative verrucous leukoplakia. The treatment, of course, is excision, and you are the people who are going to treat this. So that finishes leukoplakia. We will start the next lesion, that is oral lichen planus, which is also a oral potential malignant disorder. Now, what exactly is oral lichen planus? Oral lichen planus is a chronic mucocutaneous disorder of stratified squamous epithelium of uncertain etiology that affects oral, genital mucous membranes, skin, nails, and scalp. Basically, it is a questionable autoimmune disease or an immune system condition. We will talk about that. It's basically a skin lesion that can affect the skin and also other areas of the mucous membranes in the human body. If lichen planus is affecting the other areas of the human body, it's a normal condition which can be treatable. It is not a potentially malignant disorder. If it occurs in the oral cavity, it needs to be considered as an oral potentially malignant disorder. It affects 0.5 to 2% of the general population. Then 30 to 60 years of age is the age of predilection. As you know, all autoimmune diseases, female predilection is more. It's the same with oral lichen planus, and it affects 2.6% of the Indian population, which is quite high. Now, if you look at the etiology of oral lichen planus, the most acceptable hypothesis is the autoimmunity. Of course, there is a genetic background to it. There are a lot of dental materials and drugs that can cause lichen planus, but the patients where you see they give a history of dental materials and drugs consumption causing lichen planus, the moment you stop these particular medications, the lesion disappears. Infectious agents like hepatitis C has been postulated. What happens in hepatitis C patients is patients who are suffering from hepatitis C have an increased predilection for occurrence of oral lichen planus, and all oral lichen planus in patients suffering from hepatitis C will not respond to a conventional treatment in a normal way that it should respond. We'll come to it later when we are discussing treatment. Bowel diseases like Crohn's disease and ulcerative colitis also have an effect on the oral lichen planus. Of course, stress is a very, very important perpetuating factor for this particular disease. Some authors still believe that there is a syndrome called Greenspan syndrome, which is a triad of diabetes mellitus, hypertension, and oral lichen planus. Some authors don't believe. Whatever it is, still some authors believe that diabetes and hypertension have got some amount of effect on the clinical behavior and the way it responds to treatment in as long as oral lichen planus is concerned. Now let us see what exactly happens in lichen planus. An unknown antigen enters the oral mucous membrane. The antigen presenting cells presents it to the CD4 lymphocyte. The CD4 lymphocyte produces interferon gamma. What happens? There is a fight between the host cells and the unknown antigen. As a result of that, in the epithelium, in the basal cell layer, there is a basal cell degeneration, and all the T lymphocytes that come to fight with the basal cell layer get accumulated in the submucosa. That is why there is subepithelial lymphocytic infiltration. Classically, subepithelial basal cell degeneration, subepithelial lymphocytic infiltration is a classical histopathological picture of the oral lichen planus. So it is essentially an accepted questionable autoimmune disease or an immune system related disease. In the skin, the lichen planus presents as, remember 5 P's: purple, polygonal, pruritic papules, and plaques. It normally affects the flexor surfaces of limbs, inner aspects of knees and thighs and trunk, and also may appear on lines of trauma. This is how it appears. The classical appearance has been described as flat-topped papules giving a violaceous hue. Violet colored hue. Of course, it is also associated with some amount of itching. This is how oral lichen planus appears. We all have read about this in our undergraduation in Fitzpatrick's dermatology. This is a reticular type of lichen planus. What you are seeing here is lots of papular lesions forming crisscross lines. If you view this particular image under magnification, at the intersection of the crisscross lines, you are seeing small, small dots. These small dots are termed as Wickham's striae or the striae of Wickham. This is reticular lichen planus. This is annular lichen planus. Basically, you are seeing papular lesions in the form of rings or rounds or circular lesions. This is annular lesions. Plaque type of lichen planus. Now, this particular thing, I want your attention here, my dear colleagues. This is one type of lichen planus which needs to be differentiated with homogeneous leukoplakia. It is very, very important. The reason is, majority of the times, it's very difficult for us to differentiate between a plaque type of lichen planus and homogeneous type of leukoplakia, because essentially both are plaque lesions which are non-scrapable, abnormal, keratin-laid lesions. Now, why should we differentiate these two lesions? We need to differentiate it because somewhere in these lesions you can see some amount of erythema here. Now, if the patient comes to you with the complaint of burning sensation, let us assume if it is a lichen planus, if you start the patient on topical steroid, the lesion disappears and the patient will become comfortable. The burning disappears. On the other hand, if it is a homogeneous leukoplakia with some amount of red areas here and there, your steroid is going to help transform the potentially cancerous lesion into cancer. So you are literally supporting induction of cancer by giving a topical steroid for a potentially malignant disorder which is contraindicated. That is why in plaque type of lesions, it is very, very important for us to distinguish between lichen planus and leukoplakia. So it is my personal opinion that whenever you get a plaque type of lesion, even if it is measuring less than 2, even if you label it under a low risk leukoplakia, it is better to do a biopsy, because if it is a lichen planus, it can be treated well. Another important thing that I would like to discuss in the oral cavity is, along with these lesions, papules, you are also seeing a lot of melanin pigmentation here. Now, there is something that you need to know about melanin pigmentation in the oral cavity. Generally, on the skin, we see melanin pigmentation secondary to UV radiation or sunlight. There is no sunlight or UV radiation inside the mouth. Normally, there is melanocyte incontinence inside the mouth or inside the oral cavity secondary to an antigenic insult or an inflammatory disease. So, apart from the racial melanosis and the malignant conditions causing melanosis like malignant melanoma and the nevi, all other conditions where we see this increased melanosis, we term it as post-inflammatory pigmentation. It's called post-inflammatory pigmentation. Now, this particular melanin is a protective phenomenon that you see in healing lesions of oral mucosal disease, which is a result of inflammation. It is called post-inflammatory pigmentation. This post-inflammatory pigmentation can be seen in lesions of oral leukoplakias. It can be seen in lesions of oral lichen planus. It can be seen in lesions of DLE and SLE, which are essentially the oral manifestations. There also you can see intermingling of hyperpigmented areas with the classical lesions. You can also see oral pigmentation in patients who are having graft versus host disease with presenting oral lesions, so on and so forth. Now, this is plaque type of lichen planus. This is erosive lichen planus. By definition, erosion means moist red lesion. If a red lesion looks dry, it has to be called erythema. If a red lesion looks moist, it has to be called erosion. So you can see a lesion in the palate, you can see all papular lesions, but intermingling you are seeing with lots of red, moist red areas. This is a palatal erosive lichen planus. You can see widespread erosions here. Of course, along with the erosion, you can also see an ulcerative area in the dorsal surface of the tongue. Two areas, ulceration, moist red, erosive areas, along with lot of papular areas and some amount of coating of the tongue here. This is how erosive lichen planus looks like. This is bullous lichen planus. My dear colleagues, you will not get to see vesicles or bulla inside the mouth. You can rarely see it because majority of the diseases, what you see vesicles inside the mouth, especially lichen planus, they are all thin-walled bullae or thin-walled vesicles. What happens when the patient is putting masticatory forces on the vesicles, they rupture. And what you see is ulceration. Very difficult to see vesicles inside the mouth because it is vulnerable for damage by our eating or masticatory forces. Or sometimes if you take the history, patient might tell you that he is getting small time blisters and they are bursting and resulting into these kind of ulcerative lesions. So in a bullous lichen planus, you will only get to see ulcerative lesions inside the mouth. As I discussed earlier, this is a pigmented lichen planus. This patient was asymptomatic. He has papular lesions, he has stria of Wickham, he has pigmentations, but there are no erythematous areas in this particular case. So this is a pigmented lichen planus, which is an entity that is described also in Fitzpatrick's dermatology. This represents healed lesions of lichen planus. You just have to reassure the patient and call him for a periodic follow-up. He does not require any treatment. How do you treat oral lichen planus? Now, one important thing that you need to remember here when treating oral diseases is patients with oral lichen planus are managed with medications that were neither developed nor intended for oral diseases. And consequently, most studies lack adequate efficacy. The level of evidence is very, very poor. That's why when I'm talking about oral diseases, factors such as optimal dose, duration of treatment, safety, and true efficacy remain unknown. One thing I can tell you, when you talk about duration of treatment, it should be at least for a period of 14 to 21 days because the oral mucosal turnover, that is the time taken for a cell to proliferate and differentiate from stratum basal to stratum corneum, is roughly around 14 to 21 days. So if you are anticipating any mucosal change by giving a medicament, it should be minimum for a period of 14 to 21 days. Now, let's see how we treat oral lichen planus. Oral lichen planus is essentially treated with the help of topical steroids. Evidence says topical clobetasol is the best topical steroid that can be given for oral lichen planus, but unfortunately, we do not have topical clobetasol for oral preparation in India. There is a small difference between an oral preparation and a skin preparation. I'll tell you what is that. Now, we all know that there is action of saliva inside the mouth. So, whatever the patient applies inside the mouth, it does not stay for a longer time. The amount of time that the medication stays inside the mouth is called as the residence time of the medicine, which is most important when you are treating an oral disease. For that reason, what they do is they generally mix the medicament with an agent called orabase, which you all are aware of. Orabase is nothing but hydroxymethyl or hydroxyethyl cellulose. When you mix triamcinolone with orabase, the triamcinolone sticks to the oral mucosa, the residence time increases and the lesion disappears. So what I do in my practice is, I take a skin cream, clobetasol cream, ask them to mix with Kenacort, Tess or Casic cream, which contains orabase. I know I'm helpless. We are giving two preparations of steroids, triamcinolone as well as clobetasol. But if you want to give clobetasol along with Purabase, this is the only way that I could find out, and this is how I treat my patients. I ask them to mix both the creams and then apply, and results are very good. If you don't want to practice this particular thing, what you can do is you can use 0.5 milligrams betamethasone tablet. Ask the patient to crush the tablet, mix it with saltless butter and apply it on the mucosal surfaces on the affected areas. Why saltless butter? I have seen in my practice that initially when the patient started using butter, normally salted butter is widely available, the patients are telling they are chewing everything. It is tasty, sir, and without our knowledge, we are chewing the entire medicine. That's the reason I started prescribing saltless butter. Now, there are some recalcitrant cases. There are some patients of oral lichen planus who do not respond to topical steroids or intralesional steroids. For them, we use topical cyclosporin. Again, cyclosporin can be used as a tablet form. Crush the tablet, mix it with butter and then apply. Or alternatively, there is an oral solution that is available that is normally taken with apple juice or orange juice to prevent graft versus host disease. So you can use that oral solution as a mouth rinse. You can ask the patient to rinse the mouth, keep it in the mouth for 30 seconds and then spit. So cyclosporin oral rinses are very good and well proven drugs for treating recalcitrant oral lichen planus. And recently we have also started using topical mycophenolate mofetil. You all know mycophenolate mofetil is an immunosuppressive agent used in the treatment of a lot of autoimmune diseases. What we do here is 250 milligram mycophenolate mofetil tablet. We ask the patient to crush it, mix it with butter and apply it on the affected areas. One important thing that you need to remember here is whenever the patient applies these medicines, you will have to ask the patient to retain the medication for a period of half an hour inside the mouth and not to rinse. Number one. Number two, when the medication is inside the mouth, if the patient is getting salivation, you should always ask them to spit. Otherwise, there will be a systemic absorption of the drug and side effects, so on and so forth. So when there is increased salivation, when the medication is inside the mouth, ask them to spit and not swallow the medication. I will show you some treated cases of oral lichen planus with all these modalities that I have shown so far. You can see an erosive lichen planus here, a white lesion and a red lesion here. You can see classical papular areas and erosions here. You can see after 1 month of treatment, the patient is much better. Another erosive lichen planus on the right buccal mucosa before the treatment and after the treatment. Oral lichen planus, mild erythema, reticular lichen planus, but symptomatic. You can see all the lesions are disappearing after topical steroid therapy. Left buccal mucosa, pre and post treatment. Now, if there are ulcerative lesions and erosive lesions, we generally try and treat the patients with topical steroids, see for about a week, and if they don't respond well, we start the patient on intralesional dexamethasone. Generally, the medical colleagues have a favoritism for triamcinolone injection. We don't do that because it's very, very viscous and painful when we are injecting, number one. And if you look at the duration of action, dexamethasone is a long-acting steroid and it is less viscous in contrast to triamcinolone. That's why we dentists, we are fond of dexamethasone injection and we use routinely for intraoral injections. So you can see pre and post treatment this erosive lichen planus patient after dexamethasone injections. Generally we give it for bi-weekly till the lesion disappears, and majority of the times after 3 or 4 injections the lesion responds very well and you see significant healing of lesions here. Now one important point that you need to remember when you are treating lichen planus is on the palate and gingiva. What we need to use is site-specific appliances. Site-specific appliances, what I would like to call as a local drug delivery. If you have lesions like this affecting the gums, now even if you use it with butter or Orabase, you will seldom get a residence time of the medication here. So in these kind of patients, what we do is we prepare what is known as oral stents. Oral stents. This is similar to the sports guard that is worn by these sportsmen who are playing this boxing and things like that. What we do is we create a space between the lesion and this particular appliance so that there is ample room for the application of a steroid cream over here. So if you treat these lesions in this form, putting clobetasol and triamcinolone paste along with the stent, you will get very good results. And you can see the same patient, the lesions have totally disappeared after giving a stent. This is an example of another palatal lesion. You can see an erosive lichen planus in the palate, erosive lichen planus in the palate. Same picture that I showed you when I was discussing clinical features. So you can see after the stent therapy, the lesions have totally disappeared. I know that all the oncosurgeons are fond of treating oral lichen planosis with lasers. Yes, that is also a good modality of treatment. You can use cold lasers. You can also use surgical lasers, either diode or carbon dioxide, whatever you are comfortable with. You can remove the entire lesion. But please remember one thing, since it is an autoimmune disease, there are always periods of remissions and exacerbations. So if you get to use lasers for oral lichen planosis, what you need to keep it in mind is you need to put the patients on immunomodulation. The most proven immunomodulatory drugs for treating oral lichen planus is either dapsone or hydroxychloroquine sulfate. Sometimes, even after doing lasers, repeatedly you get patients and they'll end up having erosive lesions. For them, you'll have to start the patient on immunosuppressive drug. Azathioprine 50 milligrams OD is a very, very good immunosuppressive drug with a lot of steroid sparing effects. And most of these medications have to be given for a period of at least 3 to 6 months to expect significant amount of immunomodulation in the patient's body. This finishes oral lichen planus, and we'll go to the next disease, that is oral submucous fibrosis. Am I audible and clear?
Very, very clear. Fantastic. Slides coming very well. Highly audible. Please continue.
Thank you, sir. Thank you, sir. Now let's see what exactly is oral submucous fibrosis. Oral submucous fibrosis is a chronic, insidious disease of the oral mucosa and sometimes the pharynx. It is also, please remember, occasionally preceded by and or associated with vesicle formation. Vesicle formation is seen only in 1/5 of cases, but it is always associated with juxtaepithelial inflammatory reaction followed by a fibroelastic change of the connective tissue with epithelial atrophy leading to stiffness of the oral mucosa and causing trismus and inability to eat. Definition is very simple. It is a disease associated with inflammation. Chronic irritation resulting in inflammation, inflammation resulting in fibrosis and scarring. It is as simple as that. The etiopathogenesis of this disease is there is a strong association of betel quid chewing with the causation of OSMF. What exactly happens here? In India, on all the tropical countries, majority of them have deficiency of iron and vitamin B12. They are more prone for this. So an oral mucosa with increased susceptibility, when the patient starts chewing betel quid habit. Now this betel quid habit can be pan with tobacco, pan without tobacco, mawa, gutka, all forms of chewable areca nut. That can be with slaked lime, with a betel leaf, without a betel leaf, with the tobacco, without tobacco, whatever it is, the betel nut definitely, if it is chewed in the mouth, definitely it will result into oral submucous fibrosis. Not in all the patients, we'll come to that later. When the patient starts chewing this betel quid, there is a constant irritation, constant inflammation. Because of this chronic inflammation, there is an activated T cell and macrophages at that particular site where there is inflammation caused by irritation. There are certain cytokines that are released at that particular area, especially the interleukin 6, the interferon gamma, tumor necrosis factor, and there is an increase in the growth factor, especially the TGF beta. What do these cytokines do? These cytokines, they increase the collagen production and they decrease the collagen degradation. Normal collagenase produced inside the patient's human body fails to degrade this collagen because the collagen that is formed here in oral submucous fibrosis is abnormal, and the increased collagen in the insoluble form also is, there is some amount of cross-linking of this insoluble collagen that makes it relatively resistant for degradation by human collagenase. Finally, it results into fibrosis, resulting in oral submucous fibrosis. Of course, the literature says there is a multifactorial model of pathogenesis for oral submucous fibrosis, but the most important factor is definitely the areca nut. Now, what are the components of areca nut that is bringing about this change? We will just spend about a minute to understand this. Areca nut contains three main contents: alkaloids, flavonoids, and copper. Let's first take up flavonoids. These flavonoids causes the cross-linking of collagen and make them resistant to collagenase. Copper that is present in abundant quantities in areca nut, it upregulates an enzyme called lysyl oxidase. This lysyl oxidase, it not only stimulates fibrinogenesis but also promotes the cross-linking of collagen. Alkaloid stimulates fibroblast production, and also there is an alteration in the gene expression which results in increased production of collagen. So all these three things, they result in juxtaepithelial hyalinization, vasoobliteration, and oral submucous fibrosis. And already a vasoobliterated connective tissue, there is glycogen depletion that is caused because of continued chewing and muscle contracture, which results in further muscle fatigue, causing degeneration, fibrosis, and scarring of the muscle. I think it's very, very simple and self-explanatory, this particular table. Now, all patients who are chewing gutka are not getting oral submucous fibrosis. That is because there is some amount of genetic susceptibility. Right from 1986, most of the authors have proved that there is a HLA association and there is a genetic predisposition to this particular disease. Let's not go into the details about that. Let's talk a few words about the pathogenesis also. The histopathological characteristics of oral submucous fibrosis is nothing but deposition of collagen in the oral submucosa. That's all. So some people also would like to call it a collagen metabolic disorder. Now coming to the clinical features, you can see this in any age, especially 8 to 80 years. Will be astonished that I have put 8 years here. I belong to northern part of Karnataka. When I was doing my post-graduation, what I could see was the laborers who used to chew this particular pan masala or gutka, they used to carry their kids in their lap. And when the kid starts crying, they used to remove a little bit of gutka from their mouth and put it in the child's mouth. So I have seen oral submucous fibrosis in children, even at the age of 7 years, 8 years, and 9 years. Very sad state of affairs. So in India, males have got more predilection for oral submucous fibrosis, and the prevalence rates range from 0.15 to 14.6%. What happens in early stage of oral submucous fibrosis? Patients will present to you with burning sensation, vesicle formation. They can either complain of increased salivation or decreased salivation. Some patients might come to you with abnormal sensation of the oral mucosa. Patient will not have any fibrosis, any lesions, no blanching, nothing. They will just complain that, sir, when I use my tongue and touch my mucous membrane, I feel there is some kind of a difference, some kind of a roughness or some abnormal sensation is there. This can be a first presenting complaint. You can see pigmentations and you can see ulceration. Let's see some clinical pictures here. So I have shown you pigmentation, I have shown you redness here. This is a vesicle in oral submucous fibrosis patients, and majority of the patients, believe me, they present with this kind of ulceration. Now, the characteristic feature of this ulceration here, you will not get to see in any other patients. You know why? Because when you see this kind of ulcerations, you are seeing a brownish tinge on the floor of the ulcer here. If you see, you are seeing a brownish tinge. The brownish tinge represents the encrustations that are caused because of the accumulation of products of pan masala. This particular brownish kind of ulcers you will not get to see in any other diseases except initial stages of oral submucous fibrosis. I will show you some more pictures. In moderate stage, what happens is now you get to see blanching of oral mucosa. Blanching is because too much of accumulation of fibroblasts causing engorged blood vessels, decrease in blood supply causes blanching. Blanching especially very noticeably seen in soft palate, buccal mucosa, floor of the mouth, the facial pillars. There is a rigidity of oral mucosa. You can palpate the bands. Vertical bands will be palpable on the palate, on the buccal mucosa, and again on the retrocommissural area. Essentially, oral submucous fibrosis is a disease that starts from the posterior part of the oral mucosa. So you have to see first palatal bands and then the buccal bands and then the labial bands. Patients will feel it difficult to blow their cheek or whistling. There is a puckered cheek appearance, and some amount of patients will also complain you about a taste change, diminished or altered taste sensation, whatever it is. Another important thing that you need to see in moderate stage, you need to see is generally when a patient opens the mouth, the shape is oval. The shape is oval. When the patients open the mouth, the shape is oval in nature. Now in oral submucous fibrosis, because of the fibrosis, there is a restriction of mouth opening. And when the patient opens the mouth, classically it will be circular in shape. So they describe this lesion as circum rima oris. Rima oris in Greek is mouth. Circum, it becomes circular instead of the classical oval shape. There is a depapillation of the tongue seen in oral submucous fibrosis. The disease process, because of epithelial atrophy also there is depapillation, and majority of these patients except for gutka, they don't get to eat good food. So majority of them have iron deficiency anemia, B12 anemia, decreased in ferritin levels. That is additionally a cause of depapillation in these patients. And here you can see there is a fibrosis of tonsillar pillars, and there is also fibrosis of musculus vivulae here. This is how blanching of oral mucosa looks like. The coral pink color of the mucosa will be completely lost. You will see a marble-like appearance with varying degrees of blanching depending upon the severity of the disease. Now here again you can see too much blanching, severe blanching of this particular patient. You can also see angular cheilitis. Patient's opening is less than 4 millimeters in this particular patient, and blanching here in the labial mucosa, buccal mucosa and the floor of the mouth. In terms of uvula, there are two changes that are described. Uvula assumes two shapes. This is called as a shrunken or a bud uvula, which is a resultant of fibrosis, or the uvula after fibrosis will turn into one side, which is being described as hockey stick uvula. So you can either see bud uvula and hockey stick uvula. And in severe stages, what you get to see, the mouth opening becomes less than 10 millimeters, severe depapillation of the tongue, ulcerative lesions, decreased mouth opening, which is very, very severe, and blanching is also extremely severe, and the mucosa will appear completely white. So in severe stages, another thing that happens is patient will not be able to eat anything, and the fibrosis from the palate will extend towards the eustachian tube. Now when the eustachian tube also gets fibrosed, the patients will have a nasal twang to their voice, hoarseness of voice, deafness, hypertrophic masseter muscle because of chewing, loss of nasolabial fold and thinning of lips. So the buccal mucosa is affected in 98% of cases. Tongue involvement is seen in 37% of cases. This is how you stage oral submucous fibrosis, most convenient and accepted clinical staging. Palatal bands only stage 1, palatal and buccal bands stage 2, palatal, buccal and labial bands stage 3. Functional staging, anything more than 20 mm is A, 11 to 19 mm of mouth opening is stage B, less than 10 mm is stage C. Now oral submucous fibrosis staging is very important. You have to recognize the comorbidities to decide whether you want to go for medical or surgical treatment. Now before we go ahead with the treatment, as I told you, any mucosal lesion for that matter, please get the basic blood workup done and then B12 and fasting in studies. Don't go with CBC. In tropical countries, even if the hemoglobin is normal, if the iron stores are depleted in the body, the mucosal healing will be improper and patients might still complain of burning. So if the patient is having B12 deficiency and iron deficiency, they start treating that concurrently along with the disease. Generally, biopsy is not preferred unless there is some suspicious looking lesion in a oral mucosa. Oral submucous fibrosis is predominantly a clinical diagnosis. I'll give you an example for that. This is an oral submucous fibrosis with a red lesion with a granular appearance. These are the kind of areas that you need to look into and do a biopsy. You should not be doing biopsy in normal oral submucous fibrosis patients. Oral submucous fibrosis, essentially, the things that you need to remember by treatment is habit cessation, pharmacotherapy, physiotherapy. Wisdom tooth removal is very, very important. If you get to see that the wisdom teeth are malposed or decayed, you straight away say patient for wisdom tooth removal. What is impact is all the patients who have quit the habit will come to you for treatment. Eventually, will restart the habit again, and at some point of time, there will be decreased mouth opening. And decreased mouth opening, let me tell you, my friends, very difficult to remove wisdom tooth removal. And if you look at the evidence-based data, there is a very, very limited evidence for the treatment of oral submucous fibrosis in the English literature. It's very, very common to use intralesional steroids. You ask any dentist, any oral surgeon, they give intralesional injections. They normally treat it with a combination of dexamethasone and hyaluronidase and placentrix, dexamethasone and placentrix. Initially, when I used to do this, but I have stopped this because the patients get to become complacent with the treatment because initially they see that change, burning sensation disappears, mouth opening increases. But let me tell you, my dear friends, over a period of 6 months, if you call up the patient for follow-ups, what you will get to see is relapse after giving injections. So I have stopped giving injections for OSMF in my practice. What I start the patients on clobetasol propionate if there are red lesions. As I told you, residence time is important. We have discussed about this in oral lichen planus. If the patient is having ulcerative lesions like this, I told you, typical brownish discoloration of the ulcerative lesion. This is a classical initial oral submucous fibrosis that you can get to see. In these patients, I give the patients betnisol gargle, betamethasone tablet, powdered and dissolved into half glass of water. You ask the patient to rinse it 3 times a day for a period of 7 to 14 days. You will get to see fantastic results like this. Now, coming to pharmacotherapy, a multi-drug regimen we use topical antifungal for 5 days to eradicate the fungus because there is fungal colonization in all kinds of mucosal alterations in the mouth. We use a drug called SM Fibro, basically contains lycopene, beta-carotene, selenium, zinc sulfate, ALA and alpha-tocopherol. Curcumin is definitely helping. A lot of studies are supporting this. We give 500 milligrams BD for 3 months. And We also give concurrently physiotherapy for these patients, either in the form of balloon inflammation or ice cream stick exercise. In ice cream stick exercise, we ask the patients to stack the sticks and we ask them to keep it in the mouth for 20 seconds and remove it for 20 seconds. That is one cycle. So we ask the patients to do 20 cycles in the morning, 20 cycles in the night, and every week we ask the patient to increase by one stick. This is how gradually the mouth opening increases when the patient is on treatment. Instead of steroids, what we have started using is we have started using oral pentoxifillin, that is 400 mg thrice a day for a period of 3 months, that gives very, very good results. Let me tell you, surgical therapy is the mainstay treatment for oral submucous fibrosis. For all patients having mouth opening less than 20 millimeters, it is the best thing to do. Surgical management, submucosal resection and replacement with partial thickness grafts. Lot of people have favoritism with grafts that are used for oral submucous fibrosis. Some doctors use buccal pad of fats. Dentists have a favoritism towards nasolabial flap. But the degree of fibrosis of the flap is also a questionable thing. Most of the oncologists, they use radial forearm flap, and I would like to mention our boss, Dr. Somshekhar. He has also tried using jejunal flaps for grafting in oral submucous fibrosis patients, and the fantastic thing about using jejunal flaps is there is no post-op fibrosis of the flap. Along with that, bilateral temporal myotomy is a must, and oral stents are important post-operatively to prevent fibrosis, again caused by the surgical trauma. Now that finishes the oral potentially malignant disorders. As I told you initially, I would like to have a word regarding the normal variants of oral mucosa. If you remember, we discussed about linea alba buccalis, leukodema, Fordyce's spots, and geographic tongue. Now what is happening nowadays is patients will start having burning sensation in the mouth. They start doing self-examination and start reading the internet. And they will start feeling that they are suffering from a potentially malignant disorder. Straight away they are coming to oncology. Straight away they are coming to oncology for seeking consultation. Now, what I want you to appreciate here is when the patient is complaining of a burning sensation, you will have to ascertain two important things regarding burning. My dear friends, if there is a consistent burning, which may or may not be associated with numbness, paresthesia and taste alterations, remember, consistent burning sensation in the oral mucosa, irrespective of whether the patient is eating hot and spicy food. You are not looking at a mucosal alteration. You are looking at something else, which I will talk in the next slide. If the burning sensation is associated with food intake, definitely there is a mucosal alteration. You need to diagnose the disease, do a blood workup, eliminate candida, and treat the disease which is causing burning sensation. Definitely normal variants and geographic tongue will not cause burning sensation in the mouth. So you will have to take some time and treat these patients. Number one. Number two, if the patient is having, as per this slide, consistent burning sensation with or without numbness, paresthesia of the mucosa and taste alterations, definitely you are looking at a disease known as burning mouth syndrome. And if there is no numbness, paresthesia and taste changes, you are also looking at a disease called body dysmorphic disorder. Now, we have very less time. I cannot talk more about this particular burning mouth syndrome and body mouth dysmorphic disorder. You can go and refer to the literature. Body dysmorphic disorder is basically a mental illness involving an obsessive focus on a perceived flaw in appearance that may be in the body or inside the mouth. Now, what are the studies telling? Studies are telling that if you don't treat these patients, about 33% of them are going to be schizophrenics in future. Thank you very much for giving me this opportunity to share my knowledge with fellow medical colleagues. Thank you for your patient listening.
Thank you very much, Srinivas. Superb talk. You still need another 5 hours to cover for us. Fantastic talk. What a wealth of knowledge. I'm terribly impressed. Thank you very much. There are some questions both in Q&A and chat box. Can you just open and answer them, please?
Yes, sir. Yes, sir. I'm in the process of doing that, sir. 1 second, sir.
So, first question is, sir, is there any role of curcumin in preventing oral submucous fibrosis?
It can be used for a treatment for a period of 3 months, sir. 500 milligrams given in the dosage of BID. For a period of 3 months, there are a lot of studies which have demonstrated significant relief of symptoms, and it does not cause increase in mouth opening, sir, but there is
Good,
definitely
superb. And for students, there is commercially available curcumin. You know that people use it in triple negative breast cancer. There are some studies. Next question is, what is Orabase? Orabase.
Sir, Orabase is nothing but hydroxyethyl or hydroxymethyl cellulose that basically keeps the medicament adhered to the oral mucosa, increases the residence time of the medication inside the mouth.
Good. What is the role of tooth removal in oral submucous fibrosis?
Sir, generally in this particular generation, what we get to see is there is no space for accommodating wisdom teeth. So the moment you see that the wisdom tooth is partially covered with a gum, and if the wisdom teeth are pointing towards the cheek, if they are malposed, and if you see decayed wisdom teeth, at the first sight of inspection, it is better to advise for a removal of wisdom teeth, because that will cause traumatic lesions in the oral submucous fibrosis, and it becomes extremely difficult for us to remove wisdom teeth when the mouth opening reduces.
Super. Thank you very much, Srinivas. All good things has to come to an end. There will be a lot of questions. Maybe I'll call you back again for the second half of it, but it is superb. I'll tell you that if you read the comments, people are thanking you so much about this. Excellent. Can you also guide, is there any fluorescence visualization that can be used to identify field cancerization in oral mucosa? Are there any studies, role of fluorescence light to look at it?
There are a lot of autofluorescent techniques, and there are a lot of devices that have come in the market. There is something called as Visilite, but that is extremely expensive, costing about 8 to 10 lakhs. But I'm very sorry to say that the sensitivity and specificity of all these fluorescent techniques in diagnosing potentially malignant disorders range somewhere from 60 to 75%, and even today biopsy stands as the gold standard, sir.
Thank you.
I think people have to wait for another period of 6 months. I don't want to take the name. One researcher from India is coming out with a low-cost fluorescent visualization technique, which the device is going to cost you about 20 to 25,000. Please wait for it for a period of another six months. It has gone for patenting. It will come out in the market, sir. I'll definitely discuss with you when it comes out.
Superb. See, all the lesions you told, what is the oral screening protocol that you recommend to keep these people on?
Sir, protocol means, sir, if there are non-homogeneous lesions and erosion
what I mean to say is it annual screening, 3 months?
Sir, once in 6 months, sir.
Just a oral examination, or you
once in 6 months, sir. Once in 6 months should be the protocol, sir.
Okay, 6 monthly with just oral inspection without lugalcidine or anything, with a white light, proper thorough examination.
Sir, if you get to see any red areas, we can use lugalcidine or toluidine blue, sir.
Thank you very much. A lot of people are asking about margins. Remember, the margins remain same even though verrucous hyperplasia, verrucous carcinoma and invasive squamous carcinoma you do. By large, people believe 2 centimeters the margin for verrucous carcinoma, but still a negative tridimensional 1 centimeter margin is what is evidence-based for all of them. And a margin for high-risk lesion is at least 5 millimeter, but the norm is we do with 10 millimeters so that there is a shrinkage, and still it is 1 centimeter. So pretty much all of them are treated with negative margin microscopically, which is a macroscopic 10 millimeter and a negative microscopic margin. Thank you very much. Still there are a lot of questions, but in the given interest of time we have to end. But beautiful talk, fantastic. I know your importance. I learned a lot over last 2 decades from you. I thought my students.
Sir, thank you, sir.
Thank you very much, and heartfelt thanks from student, myself, and NBE and DNB board. Over to Navneet Singh ji.
For the presentation, and thank you very much, Professor Dr. Somashekar, for joining us. And thank you, trainees and faculty members, for joining. Thank you.